We are looking at a medical protocol today that involves taking highly purified DNA fragments, and these are extracted from the sperm cells of salmon and trout.
Right, which is already a wild concept to wrap your head around.
It really is.
Right.
And then they take that DNA and inject it with a needle directly into the most sensitive area of the human female body.
Yes, the vulvovaginal mucosa.
Exactly. So naturally, if you are staring down the barrel of this treatment, your very first question is going to be, how much is this going to hurt?
I mean, it is an entirely rational fear. You put the words needle, highly sensitive mucosa, and fish DNA in the same sentence, and, well, the brain's threat detection system just goes into absolute overdrive.
Well, 100%. So welcome to today's deep dive. Our mission today is to answer that exact, highly practical pain question for you.
Because it's the elephant in the room, really.
It is. We are pulling apart a massive stack of clinical protocols and source material on the rapid rise of intimate polynucleotide procedures. We have aesthetic and women's health clinic guides on the table, places like Injectual, Serenity Women's Clinic, the Women's Health Clinic, and Kaizen Medical.
Yeah, plus we're looking at some heavy clinical data on genitourinary syndrome of menopause from Novo Nordisk.
Right, alongside a very sobering report from the National Institute for Health and Care Excellence, or NICE, regarding alternative treatments.
It's a really dense stack of sources today.
Yeah.
But it perfectly frames the tension here. I mean, on one side, we have the cutting-edge biochemistry of tissue regeneration.
And on the other side, the sheer physical reality of delivering that treatment to an area of the body that is just packed with nerve endings.
Exactly. So where do we start?
Okay, let's unpack this, because before we can accurately judge the pain of the procedure, we have to understand what is actually inside that syringe.
Right, and the cellular environment it's being injected into.
Because if you just hear fish DNA, it sounds like, I don't know, some bizarre holistic supplement you'd buy at a health food store.
Yeah, but this is a heavily synthesized bioactive molecule.
Precisely. We are talking about polynucleotides.
Which, at a fundamental level, DNA is simply a universal biological code, right? It's just made of nucleotide base pairs.
Yeah. And the source, in this case, typically salmon or trout, is chosen because it is highly abundant and incredibly biocompatible once it's purified.
The manufacturing process is intense. They strip away all the proteins, all the cellular debris, leaving behind only these pristine, sterile chains of nucleotides.
So it's essentially just raw biological building material.
Exactly.
And the reason a patient would need that raw material injected into their intimate area brings us to genitourinary syndrome of menopause, or GSM.
Which is incredibly common.
It is. Looking at the Novo Nordisk data, the scope of this condition is massive. Around 1 in 2 women experience this as their estrogen levels plummet.
Right. And it isn't just about feeling a little dry. The cellular architecture of the tissue actually collapses.
The vaginal wall thins out, it loses its elasticity, the pH environment completely changes, and it just becomes incredibly fragile.
The tissue is essentially starved. Estrogen is, the signaling hormone that tells the cells in that area to maintain their thickness and moisture.
And when that signal disappears,
The localized fibroblasts, the cells responsible for producing collagen and elastin, they effectively just go dormant.
wow.
Yeah, so the mucosa becomes so fragile that even normal daily movement can cause micro tears, chronic inflammation, and severe dyspareunia.
Which is the clinical term for painful sexual intercourse.
Exactly.
Which brings up how we used to treat this and why these new DNA fragments are such a massive leap forward. For decades, the frontline advice was basically just to use heavy lubricants.
Right, which is just a Band-Aid.
Totally. To use an analogy, applying a temporary lubricant to severe vaginal atrophy is like having a lawn that is completely dead at the roots and trying to fix it by spray painting the dead grass green.
That's a great way to put it.
Yeah, like it might offer a frictionless surface for an hour, but you haven't fixed the biological degradation of the yard.
The underlying cellular decay is still actively progressing.
Right. But polynucleotides act completely differently. Injecting these molecules is like aerating the soil, planting new seeds, and dropping deep tissue fertilizer.
You are forcing the lawn to grow back from the roots up.
Yes. And if we look at the specific mechanism of how that fertilizer works, it is fascinating.
It really is. Because when you inject these purified DNA chains into the degraded tissue, they don't just sit there like a standard dermal filler.
Right, they're bioactive.
Exactly. They bind to specific receptors on those dormant fibroblasts. The cells effectively scavenge these nucleotides, using them as the raw energy and material required to suddenly ramp up the production of type I and type 3 collagen.
It provokes this profound structural regeneration, and it rapidly downregulates the chronic inflammation that is causing the patient's daily discomfort.
But getting those building blocks into the tissue, however, is where the biological roadblock comes in.
Because the vulva is wired by the pudendal nerve to be exquisitely sensitive, you cannot just go in with a needle without addressing the pain factor head on.
You really can't.
So looking at the clinic protocols we have here, how do they actually manage the nervous system before the procedure even begins?
Well, the pre-procedure phase is aggressively focused on pain mitigation. The guidelines from Serenity Women's Clinic mandate that patients must undergo hair removal prior to the appointment.
Oh, interesting.
Yeah, and this is crucial not just for creating a sterile field, but to ensure that the heavy topical numbing agents can make direct, unimpeded contact with the skin and the mucosa.
So the numbing really is the main event before the main event.
It is the anchor of the entire protocol. Practitioners apply a very thick layer of a medical-grade anesthetic cream.
Like lidocaine.
Typically a high concentration of lidocaine,
Yeah.
often mixed with another agent like prelocaine, to really enhance that tissue penetration.
And depending on the clinic, the patient then has to sit and wait for anywhere from 20 to 60 minutes for it to take full effect.
Right. Which sounds like a long time to just sit there.
It does. And that raises a really tough logistical question. Because the sources confirm the actual active injection time is only about 10 minutes.
Yeah, it's very fast.
So if you are sitting there for an hour, fully aware of what is about to happen, doesn't that wait time allow the mind to completely catastrophize? Like, the psychological anticipation almost seems worse than a 10-minute procedure.
I mean, from a psychological standpoint, the wait can certainly be anxiety-inducing,
Yeah.
but physiologically, it is absolutely non-negotiable.
Because of how the cream works.
Exactly.
Yeah.
The lidocaine works by physically blocking the sodium channels in the nerve endings, stopping them from sending pain signals to the brain. But it takes time for that chemical blockade to penetrate deeply enough into the mucosa. Rushing this process by even 10 minutes would guarantee a highly painful experience.
So you really need that full hour.
You do. The extended wait ensures that when the needle finally appears, the patient's physical reality is completely detached from their mental anxiety.
Okay, so the hour is up. The lidocaine has chemically blocked the nerve endings. The 10-minute clock starts. What is the physical sensation of the main event?
Right, let's get into the rim.
Yeah, if I am lying on that table, what am I actually feeling as the product is delivered?
What's fascinating here is the evolution of the delivery method itself. While some practitioners still use an ultrafine needle, many have transitioned to using a microcannula.
And a cannula is like a flexible, blunt tip tube, right?
Exactly. Instead of piercing the tissue dozens of times with a sharp needle, the practitioner makes one single entry point with a tiny needle.
Just one poke?
Yeah, and then they slide the blunt cannula beneath the skin, allowing them to fan the liquid product out across a really wide area.
And because it's blunt, it just pushes the blood vessels and nerves out of the way rather than slicing through them.
It glides right through the subcutaneous plane. This drastically reduces the sharp pain and minimizes the risk of bruising.
That makes a lot of sense.
So because of the heavy lidocaine, patients generally report the sensation not as a sharp piercing pain, but rather as a dull, pushing pressure.
Okay, a pressure.
Yeah, you might feel a gentle prickling sensation or a small, localized warmth as the liquid DNA solution physically displaces the tissue.
Let's contextualize that pain level against things people might be more familiar with, because the clinic injectual provides a really useful pain scale comparison for cosmetic injectables in their guide.
They do. It's a great reference.
On the absolute lowest end of the pain spectrum, they place Botox. It is a very shallow, rapid injection with a tiny volume of fluid, so it barely registers.
Right, just a quick pinch.
But on the high end of their pain scale, they list tear trough filler, which is placed deep under the eyes.
Oh yeah, that can be rough.
Because that involves pushing a thick, highly viscous hyaluronic acid gel into a tight space, which creates intense, uncomfortable pressure.
Intimate polynucleotides sit right in the middle of that spectrum.
Really, smack in the middle.
Yeah. The solution is very watery. It is not a thick gel at all, so it flows easily into the mucosal tissue without causing the heavy tearing sensation associated with dense dermal fillers.
Got it.
It is definitely more noticeable than a quick Botox prick, but it completely avoids the deep, visceral ache of a heavy filler.
I want to push back on this a bit, though, because I am seeing a contradiction in the clinic marketing materials here.
Oh, what do they say?
Well, Skin Boutique Essex describes the procedure as mildly uncomfortable at worst, But if you look at the protocols from Revitalize Medical, they literally list the pain category as moderate.
That's a fair point.
Is one of these clinics just heavily downplaying the reality of the needle for marketing purposes?
It's not necessarily marketing spin. The discrepancy actually speaks to the biological variability of the patients themselves.
Oh.
The difference between mildly uncomfortable and a true moderate pain rating comes down to the baseline health of the tissue being injected.
Oh, because of the micro tears and inflammation we talked about earlier.
Yes. If a patient is presenting with severe end-stage genitourinary syndrome of menopause, their tissue is already hypersensitized.
Right.
It is essentially an open wound at a microscopic level. Even with a heavy lidocaine blockade, injecting fluid into tissue that is chronically inflamed, tight, and lacking elasticity, it's going to trigger a stronger pain response than injecting healthy, supple tissue.
That makes total sense. If the tissue is already screaming, the mechanical pressure of the fluid is going to register more intensely.
Exactly. So for a severe case of GSM, describing the pain as moderate is a clinically honest expectation.
Okay, so the 10 minutes of active injections are over. The cannula slides out. But the physical reality of the treatment isn't over just because the practitioner is done.
Not at all.
What does the aftermath feel like as that massive dose of numbing cream starts to fade?
Within the first hour or so, as the chemical blockade wears off, patients typically experience a mild, throbbing stinging.
Like a sunburn.
Very much like that. The mucosa will feel sensitized, tight, and warm. It is very similar to the sensation of a moderate sunburn.
But the more intense part of the recovery isn't actually the pain, it's the physical texture left behind.
Oh, the papules.
Yes. The practitioner has just deposited dozens of small pockets of liquid into the shallow layers of the skin. This creates tiny, raised, visible bumps all over the treated area, which the medical guides refer to as papules.
They are very distinct. You can see them and you can certainly feel them.
So what does this all mean for the patient? It essentially sounds like you have, temporary bubble wrap underneath the skin of your intimate area.
That's honestly, the bubble wrap visual is highly accurate for what the patient experiences.
It might not be sharply painful to the touch, but the physical presence of those bumps has to be incredibly bizarre.
It is bizarre, but it is important to understand that the body is highly efficient at metabolizing this specific fluid. Those papules are essentially reservoirs of raw DNA building blocks. Over the next 12 to 24 hours, the surrounding tissue actively absorbs the fluid, pulling it into the cellular matrix.
So they just sort of deflate?
Basically, the bumps flatten out and integrate entirely. You might be left with some faint pinprick marks or a shadow of a bruise, but the raised texture is fleeting.
Which brings us to the logistics of those following days. All of the clinic guides, Serenity, Kaizen, the Women's Health Clinic, are absolutely rigid about the 72-hour rule.
They don't mess around with that.
No, they don't. For 3 full days post-procedure, the patient has strict behavioral mandates. They are instructed to use only the mildest cleansers to avoid chemical irritation.
Right.
They are banned from any activity that causes direct mechanical pressure or friction. So absolutely no cycling, no spinning classes, and no horseback riding.
The mechanical restriction is vital here. The fibroblasts are in a hyperactive state, attempting to synthesize new collagen networks.
They're busy working.
Exactly. Subjecting that area to heavy friction disrupts the integration of the product. It can trigger a severe inflammatory cascade, undoing the very work the polynucleotides are trying to accomplish.
And the final mandate of that 72-hour window is strict pelvic rest, meaning absolutely no sexual intercourse.
Correct. For the exact same reasons. The tissue requires a completely undisturbed environment to complete the initial phases of cellular repair.
Dealing with days of feeling like you have bubble wrap under your skin, mild sunburn-like stinging, and a 72-hour ban on cycling or sex is a serious logistical hassle.
It's an investment of time, for sure.
Which forces a direct comparison with the other options on the market. If we are weighing pain versus payoff, why would a patient choose the needle when there are pills and lasers available?
Let's look at the over-the-counter options first.
Yeah, there is a product called Gina, which is a 10 microgram vaginal estradiol tablet, now available without a prescription in the UK.
Right.
It is completely painless to insert with a tiny applicator. Why not just use that and skip the fish DNA entirely?
Because Gina relies on introducing active hormones into the body. Now, localized estrogen therapy is remarkably effective and is the gold standard for many women suffering from GSM.
But not all women.
No. It is strictly contraindicated for a massive demographic of patients. If a woman is a breast cancer survivor Or if she has a history of any estrogen-dependent tumor, introducing even localized hormones is a risk that her oncology team will simply not allow.
So they can't use it.
No, those patients are completely locked out of the easy hormonal fix. They desperately need a non-hormonal structural solution.
Here's where it gets really interesting. Because if hormones are off the table, the medical aesthetics industry heavily pushes transvaginal laser therapy as the alternative.
Oh, yes.
We are talking about CO2 or Aero-IAG lasers. And purely from a marketing perspective, the word laser sounds so clean.
It does sound high-tech and sterile.
Right, it sounds far less invasive and painful than multiple needle injections of animal DNA. But we have the NICE report in our source stack today detailing the safety monitoring of these transvaginal lasers.
And the documented complications are harrowing.
The National Institute for Health and Care Excellence provides an incredibly necessary reality check on thermal energy devices used in this area.
It really does. It must be stated that many women do undergo laser therapy with positive results.
Sure.
But the mechanism of a laser involves creating controlled thermal damage, microburns, to provoke a healing response.
And when that thermal energy behaves unpredictably in delicate mucosal tissue, the complications are devastating and often irreversible.
Yes.
I want to read directly from some of the adverse events highlighted in the NICE report because it completely changes the calculus on the pain question.
Please do.
Patients reported persistent and progressively worsening dyspareunia after the laser sessions, meaning they went in to fix painful sex, and the thermal trauma from the laser actually amplified the pain permanently.
Because the thermal injury triggers an aggressive scarring response rather than healthy collagen regeneration.
There are also reports of third-degree burns inside the vaginal canal. We were talking about severe, full-thickness tissue destruction from a device meant to rejuvenate.
And that level of trauma cascades into the surrounding musculature, too.
How so?
The NICE report details cases where the intense pain from the laser burns caused the pelvic floor muscles to lock into a state of hypertonus.
Oh, wow.
Yeah, chronic, unrelenting spasms that require intense physical therapy to just unlock.
That sounds horrible. But the complication that stood out as the most alarming was the structural damage. The report details cases where the burns healed by creating a crescent-shaped fibrous band mid-vagina.
A stressor?
Exactly. The laser created a thick, unyielding band of scar tissue that partially blocked the vaginal canal, making physical penetration virtually impossible without agonizing pain.
It's a tragic outcome for something marketed as a rejuvenation treatment.
So if we pull all of this back to the core question of the deep dive, does the polynucleotide procedure hurt?
Yes. Despite the heavy lidocaine and the microcannulas, injecting fluid into highly sensitive, often atrophied tissue involves mild to moderate discomfort. You will feel pressure, you will feel stinging, and you will have visible papules for 24 hours.
But when you contextualize that moderate 10-minute pinch against the daily, relentless chronic pain of untreated vaginal atrophy, the scale tips.
Absolutely.
And when you compare the biochemical safety of polynucleotides, which simply feed the cells raw building blocks, against the severe thermal risks of lasers that can leave you with third-degree burns or permanent fibrous strictures, those tiny needles suddenly seem incredibly mild.
You really do. It is a highly tolerable, immensely logical alternative, especially for patients navigating life after oncology treatments.
If we connect this to the bigger picture, this shift from thermal damage to biochemical regeneration is profound.
We're moving away from the old medical paradigm of either burning tissue to force a reaction or just coating it in temporary lubricants. We are finally learning to speak the fundamental language of the cells themselves.
Which leads to a final thought for you to mull over as we wrap up today. We are now successfully taking the purified genetic material of trout and salmon and using it to painlessly reprogram and rebuild the most intimate, sensitive, and age-affected tissues in the human body.
It's an incredible breakthrough.
It is. If fish DNA can be used as a universal scaffolding to rebuild a collapsing vaginal wall, what other degrading tissues are next?
That's the real question.
Right. If these bioactive molecules can wake up dormant fibroblasts here, how long until we are injecting them to regenerate the cartilage in our failing joints, the degrading discs in our spines, or even the neural pathways in the brain?
The limits of what we can repair using the building blocks of other species are suddenly looking very, very vast. It completely redefines the boundaries of human tissue repair.
It really does. So the next time you find yourself fearing the needle, just remember that sometimes the most complex biological problems have solutions that are surprisingly elegant and highly worth the pinch.